Advaita from Mumbai. I think Dr. Sadashivu and Dr. Venugopal are not joining. I'd also request the speakers for the Med Talks to also be a part of the panel. So before I start, anybody here has given any of the MET inhibitors to any of the patients? Because I have never seen the drug or I have. So Advaita, you have given. So please share your experience.
Yeah, so I have used it in one of the patients who turned out to be having a MET14 skipping mutation. This was in a first line setting where I had luckily had an access to capmatinib for this patient. Patient in side effect profile wise, as we've seen in most of the trials, fatigue was one of the most commonest symptoms, and peripheral edema was also there initially. But then this patient actually, through about 6 weeks or so, this patient then started tolerating the drug well. We continued the capmatinib for almost 9 months. First evaluation at 4 months, patient had a partial response on the PET scan. At 9 months of follow-up, this patient, unfortunately, because of the lockdown, could not reach Bombay, and the compassionate basis drug supply also stopped because of the pandemic. And unfortunately, he progressed about 4 months after stopping the drug and died because of CNS metastasis. That has been my experience with one of the patients that we've had.
For sure. Any other panelist who has used any of the MET inhibitors?
Yes, this is Dr. Akhil. I also used MET inhibitor while I was at TMH Mumbai. So the patient received capmatinib from the compassionate access program. The patient was actually post chemo radiation, and the patient had progressed after 3 months of completing chemo radiation. The patient had significant amount of pneumonitis, so that was a very inhibiting point for us to start treatment with capmatinib, because capmatinib is known to have interstitial lung disease as one of the important side effects. So we did PFT, we did a baseline NCCT thorax, and after explaining the options, we went ahead with starting capmatinib. And the patient responded to it too well. The patient had partial response at 6 months, and the patient continued on it for close to 1.5 years on compassionate access. And in fact, the patient had very PS of 2 at the baseline when we started capmatinib, and the patient was PS1 after 6 months. So drug worked well, and the patient did not have any worsening of the pneumonitis, and that was a good point.
Thank you for sharing, Dr. Akhil, because it gives us more confidence for using this drug, and at least you know that people who have handled this drug are able to give their viewpoints in this panel. So, coming to a panel, a Bandor case of a 60-year-old female, no smoking history, presented with cough, was diagnosed to have NSCLC adenocarcinoma stage 4 with brain metastasis and adrenal and bone mets. And you can see the CT scan showing multiple nodules in the left lung. So, what would be a routine practice? Would you test these patients for oncologic driver, or would you directly go for treatment with chemotherapy or an immune checkpoint inhibitors? Naresh sir, in your practice?
Good evening, everyone, and thanks for this panel. So, because patient has the brain mets and the disseminated disease, so two things will be in my mind. The brain mets, so obviously because if they're multiple and not suitable for the sort of like SRS or SRT, then maybe the whole brain RT will be the first treatment to start with. And if the patient is not so symptomatic, can wait for some time to have the NGS panel or some other way to find out the driver mutation, like common driver mutation, then I would like to wait. Otherwise, maybe that I would have the inclination to give the 1 cycle of the chemotherapy and then try to get the comprehensive genomic profile for the patient, being the adenocarcinoma, being the non-smoker.
So, do all the panelists send NGS panel for the patients, or do you just send the EGFR, AL, cross, PDL1 testing panel? Because we are bound to miss MET amplifications or exon 14 skipping mutations if you don't test for it. We have just started testing for it since about 2 months. But prior to that, I'm sure we would have missed most of our all of our MET patients because we never send NGS for our patients. What's your experience?
Venkat, can I come? Yeah. So what we follow is that I think we, on a more practical level, sending a complete genomic profile is very difficult for patients upfront. What all of us, I think, are commonly doing is to do a limited panel of NGS, which is looking at the 7 or 8 common driver mutations or targetable mutations which we can actually use. So most of the panels which are currently being done at our center, we look at the EGFR, AL cross, PDL1, MET, HER2, and of course, in certain situations, the NTRK proteins. But it varies from different lab to lab, varies from different center to center. But at least these 6 or 7 markers are the ones which we would definitely look at.
The take home is basically try to at least do your panel against all the currently available actionable mutations and just not restrict yourself to EGFR. I'm sure soon these drugs would become more affordable and easily available to our patients.
Can I add one point here? It looks sometimes very funny to see the PET CT scan in a patient who already have the metastatic disease, which costs something like 15 to 20,000 depending on the center. And the same is the cost 15 to 20,000 for most of the comprehensive genomic profile which are now available, covering all the actionable mutation, at least the actionable mutation for which the drugs are now available in India. So it is very important to prioritize that we want the PET CT scan, which most of the time remains of no use, versus the comprehensive genomic profile.
Yeah, I think we should prioritize both. All the panelists, please chip in. It's you can all participate. This is not a Viva Voice exam, so please give your suggestions and what we do. As I said, we have started doing it. I'm sure we have missed a lot of our MET patients before that. So in this patient now, once you know that he's MET positive and PDL1 positive, what would you do? Would you add a MET inhibitor or would you change to IO because he's PDL1 positive? Or you'll add chemo plus IO. So this patient has PDL1 more than 50% and also has a exon 14 skipping mutation.
So from my side, if patient has a targetable mutation, then I will go for a targetable mutation first, because in these patients the chances of immunotherapy responding is very less. And the inhibitors are better in terms of responses also.
That's an excellent point. I'll come to this later. So all the speakers covered about MET positive lung cancers and exon 14 and how they behave, what they do, and we did learn that MET is an important regulator of growth, development, wound healing. So once the hepatocyte growth factor activates the MET, it goes downstream to the RAS, RAF, PI3K, and SRC kinase pathway. So that's a mechanism of action. So I just want to know, when we talk about a MET aberration, should we as an oncologist just focus on the exon skipping mutations, or do we look at other nucleotide variations, amplifications? Are they also important?
Regarding if you're asking regarding whether other kinds of MET amplification, whether that are also targetable,
are important, significant.
So in that geometry mono 1 study, that they have shown that those who have a gene copy number more than 10 of amplification, they have some responses, but it was not as good as exon 14 mutation. And some amplification can be just it is not a driver mutation that is being seen in that study. So all other kind of mutation may not be the targetable mutation.
Okay.
Yeah, Venkat, there was a very interesting data on patients who were receiving EGFR inhibitors as first-line therapy and then had progression, in which there were multiple different mutations which were actually analyzed and reviewed. And in those subgroup of patients, there was not only the MET exon 14 skipping mutation, but there were other amplifications of MET also which were actually noted. There were a few studies a couple of years back which were looking at combination of EGFR as well as capmatinib as a second line in patients who had those amplifications. Some tried switching over to savolitinib as second line, and some also looked at capmatinib in second line for the exon 14 skip mutations. I think it is very clear with all the data that the exon 14 skipping mutation are much more sensitive towards these MET inhibitors as compared to the amplifications or other abnormalities which we see.
Yeah, before I would come to it, Dr. Aditya had a nice presentation on MET amplification tepotinib in this patient. So, Dr. Aditya, you're there. Do you think the response is as good as what you would get in exon 14 mutation based on what you presented? I think Dr. Aditya is not there, but whatever he presented showed that it does seem to work in excellently. The median PFS is almost similar to what you would get with exon 14 mutations. Okay, so they are very rare. They tend to occur in elderly, smokers. Brain metastasis is the most common, and as already presented by Dr. Akhil, that it is kind of more commonly seen in patients who have pulmonary sarcomatoid carcinomas. So coming on to the prognosis, overall, how do the MET amplificate, MET altered cancers do? Both of you, Dr. Advait and Dr. Akhil, shared your experience, but generally, what is the overall outcome of these patients compared to, say, an EGFR or an ALK mutated patient?
So outcomes actually are dependent on what treatment options we have. Now, what has happened, for example, you mentioned about EGFR, the sequencing of therapy has actually led to improvement in the overall survival in these group of patients, where you use a third generation in the first line and then you would use something else. I think we are still very early in terms of drug development for MET, although there are 3 or 4 different agents which are available. We still do not have a large number of patients in terms of a clinical experience and a scenario where we would look at sequencing, and those trials are also very difficult to be done due to the sheer small number of patients exhibiting this MET exon 14.
Right.
Dr. Naresh Somani, what any further input?
So I just want to make a comment in the sense that if you look the history of all the EGFR and the L, the all first generation, rather in almost all driver mutation, we initially had the PFS of somewhere 9 to 11 months. And as we advance in second generation, third generation, we almost doubled or even crossed the double figure. 18 months, we talk 24 months with the osimertinib and so on. So maybe that you take it like this way, that the capmatinib is the first drug giving you 9 to 10 months or so in the untreated patient. And maybe with the advancement of the science, soon you will have the drug which will be doubling the PFS in the MET exon skip mutation also. The important thing here is that the percentage of the MET exon is higher in the squamous compared to the non-squamous. So there is a thought process in your mind that selectively we should study the squamous cell patient, if not the EGFR, something like the MET or HER or something like that. We should not exclude the squamous cell patient simply that the histopathology is the squamous. We start the chemotherapy, but parallel to that, we always try to establish the MET exon 14 skip mutation in that.
So we have retrospective data before the MET inhibitors were available. They went and looked at patients, and they overall did tend to do worse than patients who are MET wild type. So yes, they tend to have worse outcomes than patients with who are not amplified. And again, retrospective study shows that average median OS in this patient is only 8 months, and with these MET inhibitors kind of crossing 12 to 14 months now with these patients. So
exactly like the BRAF.
BRAF, yes, absolutely. So what would be so we discussed that yes, we need to test them, but what would be the ideal way to test for MET aberrations? Would it be a PCR? Would you do a liquid biopsy? Would you do an NGS? Would you do a DNA or an RNA based NGS? What is the best way to detect an MET aberration?
I think looking at, sir, please go ahead.
Akhil, Dr. Akhil?
Yes, so definitely RNA-based NGS is the most sensitive way, because here we are able to get details about the exon 14 skipping mutation, plus also we'll be getting details of the amplifications. Though I agree that skipping mutations are the most sensitive to the TKI, but for amplifications, if it is significant, second line TKIs are accepted and in the guidelines. So for skipping mutations, I will use it in first line, but for amplifications, I will reserve it for second line or beyond. So I would like to use RNA-based NGS, though always not feasible for doing RNA-based NGS.
Yes, that's what our molecular oncologist says, that it's very difficult to handle RNA, and we tend to do our fusions for ALK and cross by RNA. So they say it's very dependent on the quality of the material. DNA, they are comfortable. So, but as you said, ideal would be an RNA. NGS is the ideal. Obviously, you can't do it by IHC or FISH. So if you want to diagnose MET aberration, best is to go with an NGS based, which has both a DNA based and an RNA based platform. Any of the other panelists wants to add any role? Because I remember the study had a liquid biopsy for detecting MET abrasion, which is much kind of acceptable in the sense that if you don't have tissue, you can look at the. I'm not sure the speaker is there, but what was the? Did they look at simultaneously at the tumor tissue, or just they looked at the blood? But as per that study, they used a garden panel, and they did manage to find MET aberrations in their study.
Yes, in both Nile study and Vision study, the MET mutations were well detected by the Garden 360.
So I think
There is a good concordance between the tissue as well as the liquid biopsy. But as I said, it depends on what platform that you're using for the test. And I think here the selection of the test really becomes important and where you're sending the sample. Otherwise, you may land up doing the test but may land up with inconclusive results.
yes, I think the point is currently tissue is the best, but liquid biopsy is being done in trials. So if you are unable to get it in the tissue, you can always go for a liquid biopsy, but better to send to a proper, reliable lab and a reliable test. So what are the available and yes, MET inhibitors? Which should you choose? Because we had Dr. Amol speaking on capimatinib, Aditya on tepotinib, and Avinash on amivantinib, and Dr. Tanmay on the antibody, I can't even pronounce it, and Dr. Akhil on savolitinib. So would you prefer your drugs? Would you choose those as a winner, or currently we can't say which is better?
So the basic idea appears that whichever is available, use it at the most upfront possible. So both capmatinib and tepotinib were available on compassionate access. Now capmatinib is out of compassionate access. Tepo, I think it is still available for few patients on compassionate. But later on, capmatinib is coming as a phase 4 studies in India. And I think those will be the pivotal ways in which we will be able to use in more and more patients.
What about savolitinib, the drug? Is it available anywhere?
No, not yet available.
No.
Yeah.
Savolitinib is currently done only phase 2 studies. I think phase 3 studies are also undergoing. So if anyone has phase 3 study of savolitinib going on, I'm sure everyone would love to know whether there are studies going on in India.
If you are unable to get any of the drugs, what about crizotinib? Because crizotinib is also a MET inhibitor. Suppose you have some patient, would you put your patient on crizotinib?
Can put, but I would try to use it in second line then.
Second line. Okay.
I would probably offer chemotherapy to this patient if I don't have any other
Options.
There is good data from the second line data post osimertinib failures where the Atizo, Bev, Natalie and Carbo regimen actually works well in these glucose patients.
So I will say it in that way.
Can you see my
That,
screen?
for the poor man's, the cabozantinib is one of the MET inhibitor, especially with the generic availability.
Yes.
And we all have the tendency to use the 4 drugs, including the bevacizumab and atezolizumab. But if you look at that study, the originally it is only the AGFR and ELK patient to the tune of the 15% were there. But we all are extrapolating it for the MET, for the BRAF positive patient, for everyone. I don't know how much right or wrong we are.
This kind of even summarizes it. Even crizotinib has shown about 30% response rate, and we don't have a fully published phase 3 trial of MET inhibitor. All of them have been on either phase 2 or a phase 1 data. So even in the crizotinib data, you had patients having a median duration response of 9 months, which is like about 9 to 11 months with the capmatinib, and tepotinib has slightly shown better. So I just don't know as to which one would be the drug. I think whatever is available, as Dr. Akhil said, you would choose that one. I found geometry as a very complicated trial. There were 7 cohorts, and they were like choosing which mix and match and what. Amol, is that? So, any ideas on the design of this geometry trial? I have never seen such a complicated trial in my life with 7 both first line, also the second line. So, based on this geometry trial, are you convinced for using capmatinib in your treatment naive or pre-treated cohort? Anybody? Yes.
The response rate seen with capmatinib was 68 to 69% in upfront exon 14 mutation. So
Yes.
I think that is quite enough to say that we can use
Yeah,
it.
could do that.
The disease control rate is something 90 plus, 90% plus.
Yes. What are the, I could understand this slide. What are the, do we know the mechanism of resistance to these MET inhibitors currently? Because what do you do? What do you put your patient after this capimatinib or, your other drugs like tepotinib? Are they cross-resistant? Can we change the patient to savolitinib, progress on capimatinib? Is there any data out there?
So at least there is no role for crizotinib after capmatinib, that is for sure.
Yes.
And the conventional wisdom is to give the chemotherapy doublet or maybe Beva plus IO to add in that, but not the single agent IO for sure.
Absolutely agree that there currently no data of a second MET inhibitor after giving a first line MET inhibitor. So no studies, and I would also prefer chemotherapy in this kind of patients. So what are the toxicities? I think Dr. Advaita and Dr. Akhil already said they saw this peripheral edema, and did you notice because creatinine increase was seen in 20% of patients? Was the peripheral edema really bothersome for the patient?
No, it wasn't really bothersome, but it's similar edema that one would get if we are starting a CML patient on imatinib and it takes it for 6 months and the patient gets peripheral edema, some puffiness of the face, but it generally settles down. The good thing about the peripheral edema with this drug is that it settles down after initial few weeks to months, and then the patient becomes better.
And as you see, major, there are very few grade 3, grade 4 events, and very rare to see any hepatotoxicity or nephrotoxicity or,
No, we didn't see any rise in creatinine with this patient. So
yeah,
that is
doesn't seem to have any hematological toxicity.
yes.
Very good safety profile. Again, this was discussed in the MET amplified. Continuing the case, this patient was started on capimatinib 400 mg to access had and the scan done after 6 months had stable disease, and then later the patient progressed. In these patients, would you add a PDL1 with the MET inhibitor? This is already raised, and as you said, most of the patients who have targetable mutations don't do it with IO, and this is what it took. The water is flowing upwards rather than flowing downwards, saying that better to avoid immunotherapy in these patients. But again, these patients adding chemotherapy is also associated with poor outcome in MET inhibitors in MET NLCLC. But I was very intrigued by the presentation by Dr. Tanmay about telocituzumab vedotin, because that's a combination of a chemotherapy and a MET antibody. Is Dr. Tanmay there? But it's still, it's just an abstract. We are yet to see the paper. I don't know how many years or decades before it really comes to us, or whether it will really come to us or not. So we have spoken a lot about a drug which I have not seen, never used, and which is very rare. And I think we are early. But any of the panelists wants to say anything? I think all of you are brilliant and learned a lot from your experiences. That way, Dr. Akhil, Dr. Naresh, anything else?
And something funny or maybe good is that the name of the drug, first time I'm finding it, something like Indian name, Rahika. So I don't know what is the logic for that, but it looks like Indian name.
Any other questions? Anybody else wants to ask? Anybody who's in this Zoom as a participant wants to give their comments is free to there. Is Kumar sir there? I can trouble him, or Vanita madam on their experience with MET inhibitors. Or Vijay is there, Dr. Vijay?
I think the case which I shared was common to Kumar sir and me and Vanita ma'am.
Vanita madam. Okay. Okay, then I will close this panel. Thank you very much, all of you. It was great meeting all of you online. Hopefully next year we'll meet in person.
Thank you, Venkat. Thank you so much, sir.
Yeah, thank you, Dr. Venkat, and thank you all panelists. Now I request all of you to join for a tea. We'll again meet at 6 o'clock here only.